So, good morning, everyone. Good morning, everybody. So, thanks so much for everybody for coming here. We have a really quite an extensive schedule ahead. We are going to have some talks from our net experts from Cork and Dublin. I want to thank Derek Power and Criostóir for hosting us here and enabling this to happen. So thank you very much to them. And I want to thank Hussein Almeamar and Dermot O'Toole, Ristéard Laoide for coming here. And thanks to all of you for coming down. We had a great night last night. We had 85 people. We had a great community of discussions and dinner. I think new faces found it very helpful, as did the old. It was great to see both. I want to thank the hotel for last night and today. The hotel has been extremely helpful to us. And also thanks to our sponsors, which is Ipsen Pharmaceuticals and Advanced Accelerator Applications, which is a Novartis company. And we have some representatives here from them with us today, but thanks for making this possible to do. And we also have some representatives from the Irish Cancer Society with us. We have Sinead and Donna, and they have daffodils, so you can recognise them. They have some information if you want to take that with you. They are producing a net booklet, which will be available to all the daffodil centres, and we've had some input into that, and I think that'd be great to have that around all the country in the daffodil centres and where all the various outlets, so that'd be really helpful. We are we're working away in the background trying to advocate on your behalf and to improve services, but also provide supports to patients. We have an active Facebook group which Eoin O'Leary and Mary O'Brien are running, and that works really well. And then we have a new website, new domain name, new logo, and Eoin and Mary will talk about that later this morning. We are a registered charity, and I do want to acknowledge in the past year we've had quite a lot of donations, and some people have donated amazing amounts of money. We had Ruth Kelly Brady from RD, who she's a soprano singer, and she did a concert. Over 400 people attended, and she raised over €11,500, which was an amazing amount of money. Caroline Greville ran the Women's Mini Marathon with a group of people, and she raised over 7,500. Last night, Millie Shanahan had done a coffee morning and over 3,300, I think, euro. And this morning, Margaret Flannery's father gave me a cheque for, I haven't even opened the envelope, but I think it's, how much? €5,000. So, thanks to everybody for doing all that, and we will. So, our organisation is all volunteer. Nobody takes anything out of it, and so any of the money is all put to the benefit of patients. We will try our best to use it wisely. But events like today, they are costly, but it's really beneficial. And we know that there are things that need looking at for patient services going forward, and we'll use that money to the best possible way that we can. But thank you all. So with that, I'm going to invite Professors Derek Power, Criostóir, and Hussein Almeamar to just, if you can sit up here at the front so people know who you are. And Derek is going to start his presentation.
Great. Do you want that out? Or? Yeah, no, I'll get you on now. If I get behind it. You can leave it. Morning, everyone. Thank you very much for coming. So Derek Power is my name. I can see a few people I know. Thank you to Mark for organising all of this, and to Eoin and Mary, who I know well, for organising it. And I'd like to welcome Professor Ristéard Laoide, who's Director of the National Cancer Control Programme. So this is fantastic. This is, what number year is this now, Mark? 11, year 11. Fantastic, and it's growing every year, thanks to you and Tommie. So I've been asked to speak on if you're newly diagnosed what should you know? So I'm going to recommend a couple of websites to go to because this takes in everything, a lot more detail than I can talk about this morning. So Mark alluded to the Net Patient Network website, that a huge amount of work has been done from many of the people I mentioned. Fantastic resource for everything you need to know when you're newly diagnosed. Mark is the president of the International Neuroendocrine Cancer Alliance, INCA, another fantastic website you can go to that tells you really everything you need to know about NETs. Documents like this: what's a primary neuroendocrine tumour, what's a secondary neuroendocrine tumour, what about the pathology, everything that goes with it. Everything is here on this website. So in Ireland, in our country, we have a National Cancer Registry. And again, you can go onto this website, just Google NCRI, and you will see everything about NETs. NETs are increasing every year. There's about 24,000 cases of invasive cancer in Ireland per year. NETs are a minority of that. So the incidence is very small, which means the number of new cases every year is only about 200, 250. But on a positive note, the prevalence is very high because many patients with neuroendocrine tumours, whether it's localised or advanced, can do very well for years and years and years. And therefore, the prevalence is very high. Here's another website. I trained a bit in the US. Cancer.net is a very simple website to go onto. This tells you everything you need to know in simplistic or complex terms, whatever you like, about any cancer, in this case, NETs. And then, of course, the Irish Cancer Society has a good web page on neuroendocrine tumours, and we've representatives from the Irish Cancer Society here today. So what are NETs? So very simplistically, these are cancers formed by cells that make hormones in response to signals from our nervous system. They're most commonly diagnosed in the gastrointestinal tract, more specifically the small bowel and the pancreas, but anywhere in the gastrointestinal tract, and also in the lung. And this is an example of where neuroendocrine tumours can be, and the hormone-producing cells that release hormones into the bloodstream from any of these organs. So you can get a neuroendocrine tumour pretty much in any of these locations. So what about risk factors for NETs? I'm always asked about this. So I just thought I'd put up the standard risk factors for cancers. So about 40, maybe 50% of most cancers are due to these risk factors. And I think many of us know these. And the Irish Cancer Society are very good, the NCCP are very good at publishing documents through the HSE and other organisations to highlight to us that you should really try and pay attention to these risk factors for cancers. So with respect to NETs, there is no real identifiable risk factor. That doesn't mean on the previous slide you can do all these things and go mad. Of course it doesn't. But in neuroendocrine tumours, these risk factors aren't really associated with these cancers. So there's no avoidable risk factor, to my knowledge, that's been found, either in the environment or in diet. There is inherited syndromes. These are very unique, genetically driven syndromes like MEN, multiple neuroendocrine neoplasia, and many others. I won't go into this, but these are the minority of NETs. Other medical conditions, if you've acid issues in your stomach, that can be responsible for NETs. And then there seems to be a little bit more of a predilection for females versus males, but it's not hugely different. So what about symptoms? Many of you in the room, I'm sure, had a very difficult journey to getting your neuroendocrine tumour diagnosed. And in fact, in contrast to other cancers, they can often be misdiagnosed as some of these conditions, like irritable bowel syndrome, asthma, diabetes. Many of these conditions can be a prodrome to a neuroendocrine tumour, so they can be very difficult to diagnose. And I'm sure many of you, when we do the question and answer session, might be able to relate to this. So, I mean, I'm not going to go through all this in detail, but some of the symptoms can be very general, loss of appetite, fatigue. Some can be a little bit more specific to where the tumour is. For example, if it's in your lung, you might have a cough or a wheeze. If it's in your bowel, you might have an altered bowel habit. So the symptoms can be a bit vague, and they can be due to release of hormones. You might have diarrhea, for example. Your blood sugars might go high or go low. You might be anxious because hormones being released from your adrenal glands. You might even have a rash due to different hormones being released. And then there's the extreme example of carcinoid syndrome. So this is due to really excessive release of a hormone called serotonin. So you may sweat, diarrhea, You may sweat, diarrhea, you may be weak, and so on. And Mark and Tommie and others have this crisis card that patients who are at risk of carcinoid syndrome with neuroendocrine tumour in the liver can carry. Because if you go to a hospital, A&E say, for example, you're not going to meet a NET specialist in A&E. And if you're at risk of carcinoid syndrome from your own doctors, and you know this, you can carry this and give these to the doctors or nurses who are looking after you, for example, in an A&E, who may not know anything about this. And I think we've raised this, Mark, at a few meetings previously. So how are NETs diagnosed? Well, I'm not going to go into it in great detail. The most important thing probably is to get a sample of the tumour, whether it's from your appendix, from your lung, from your liver, from your pancreas. The biopsy can tell us loads. We'll talk about that in a second. Blood tests, urine tests, that can tell us how active or how functional the neuroendocrine tumour is. Scopes, that's what endoscopy is. Professor O'Toole is here, who's an expert in endoscopy. Scopes up, scopes down, endoscopic ultrasound called EUS. All of these can diagnose NETs and get a biopsy. Ultrasound, CT scans, MRI scans. And of course, the real hot topic is gallium PET scans. And I'm probably causing a bit of annoyance in people under the surface when I say that. Where's my gallium scan? But there's been great progress in Ireland with gallium scans. When I started working in Ireland 13 and a half years ago, there was no gallium scans. And even 3-4 years ago, there was no gallium scan in Ireland. Now there is. So we're making progress, and we have a lot of discussions about that today. Pathology, I'll be very quickly. I mentioned the biopsy. There's different grades of neuroendocrine tumours, 1, 2, 3. There's different activities called Ki-67. Generally speaking, the lower the percentage, the more indolent or less aggressive the disease, the higher percentage the opposite. And this is really a slide from the INCA website that just summarises NETs can be grade 1, 2, 3, or can go on to a higher type of disease altogether called an NEC, which is a neuroendocrine carcinoma. The point that this slide makes is these diseases are heterogeneous. They're not all the one disease. All NETs are not the same. Some patients may have had an undiagnosed NET for 15 years before they come to a clinic. Others may 15 months, and they could go into big issues. So these are heterogeneous diseases, and everybody has different stories. The treatment is different for everyone. All NETs are not the same. So the treatments, I'm not again going to talk about this in detail, but the treatments can be, surveillance can be a treatment. Many of you, some of you may have had a neuroendocrine tumour diagnosed by fluke. You might have had your gallbladder removed. You might have had your appendix removed. You might be having a surveillance colonoscopy, or even in the context of the National Cancer Screening Programme for bowel cancer, you may have had a colonoscopy, and lo and behold, there's a small polyp, a little bit of fatty tissue in your bowel, and there's a neuroendocrine tumour in it. So how do you treat those when it's incidental and there's nothing else? Really just surveillance, and we'll talk about that maybe in the question and answers. And there's a whole variety of treatments. If I'm to make one sweeping statement as the best treatment, it's probably surgery. Surgery is the best treatment for most NETs, not all, but most. And we have my colleague, Professor Súilleabháin, here to talk about the role of surgery, and whether it's major surgery or smaller surgery, etc. He'll talk about that. But many of you in the room may have experienced some of these treatments, the somatostatin analogues, some of the more modern drugs which target genetic changes in the NET, drugs like sunitinib or everolimus. There's PRRT. We have an expert here, Dr. Hussein from Vincent's, who'll speak about this. Chemotherapy, immunotherapy is coming online, radiation, and so on. You can read it all there. So there are many, many treatments, and the reason there's so many is the diseases are so heterogeneous. So if you're looking for newer treatments, just say you've gone through an awful lot of these treatments. Newer treatments, patients often ask me about trials, clinical trials. So I deal a lot with clinical trials, again, in a government-funded organisation called Cancer Trials Ireland, that you can Google and see. Any trial that's open in Ireland is registered on that website and on another website called clinicaltrials.gov. But with respect to NETs, Mark is super involved in this. You can find clinical trials that are open in the world for neuroendocrine tumours on this website. And it's made very simple with links on this website. You just select your condition, select where you are, and see if there's a trial. So that's a very good resource whether you're newly diagnosed for your own education or whether you're later on in your disease journey. And what I often forget, because I'm so busy with making management decisions and liaising with experts, many of whom are here, is coping with the treatment. I often underestimate how difficult it is for families, friends of patients to cope with the treatment and patients themselves. And this website, cancer.net, has very, very good links on coping with the treatment, the physical side effects, the financial side effects, the emotional side effects. And caring for a loved one with a NET is really very important. There are many of you, many patients in the room who've gone through big surgeries, big treatments, both in Ireland and overseas. And this can be hugely difficult. And support from family and loved ones is really, really, really important. And then on a positive note, survivorship. This hardly existed in cancer when I first started working as a consultant about 13 and a half years ago. But survivorship now is a real deal in cancer. Right now, in the Silver Springs Hotel on the Quays in Cork, the Irish Cancer Society are holding a meeting on survivorship. It comes once a year, and who would have thought we'd be talking about survivorship? There is about 190, 200,000 people in Ireland today who are surviving cancer, who are finished their treatment and are in the survivorship. So this is a very, very important area, and I think there's a lot of work been put into this by the Cancer Society and other societies in the country. What about your follow-up care? Very simply, when the treatment is finished, whether it's surgery, whether it's the PRRT, whatever, whether you're off treatment for a while, you're linked in with your oncologist, with your gastroenterologist, with your NETS team, to look for recurrence, and how frequently you have scans and bloods and everything depends on what particular type of neuroendocrine tumour you have. It's very important we pay attention to side effects. PRRT, for example, might affect your bone marrow long term, so we check blood tests and so on, and this is something that's very important. And I think as a patient, and as families and friends of patients, keeping your own records when you got your treatment, when your next clinic is, when your next scan is really, really critical, because I think you as patients can make a huge difference in your disease, and Tommie is a classic example of this, Tommie Gorman. So a final slide, we have a lot of success in NETs. We all hear about negativity with the HSE, with A&Es, with difficulty getting treatments, but we should really acknowledge the success. I mean, this NET patient network didn't exist 11 years ago. Now look, there's probably going to be about 150 people here today, Mark. There's 150 seats here, I think. We all talk regularly. Dermot O'Toole, Criostóir, other surgeons, myself. The treatment abroad scheme was an unknown entity years and years ago. Now it's fantastic, I think. The NCCP, we have the director from the NCCP here. Again, this didn't exist over a decade ago. Now we organise cancer services way better than we did 10, 12 years ago. And we have recognition of regional centres for NETs. I think it's very important to understand that every hospital can't do everything. So there has to be centres that deal with cancers, the incidence of which is uncommon with this particular cancer, NETs, but the prevalence is high. So we've obviously got the National Centre with Vincent, led by Professor O'Toole and all his team. We have our centre in Cork in the Mercy that links in with regional hospitals, and then we have the Céilta University Group in Galway. So that doesn't mean other hospitals aren't involved, but you have to have a number of centres that can be the go-to centre, so to speak. And there's multidisciplinary team meetings regularly in these hospitals to talk about NETs. You can see the cartoon over there, everybody that links in. And of course, the most important part is you, the patient, right in the centre. So thanks for your attention.
I think that was a great overview from Derek Power of having NETs, getting diagnosed, and what your journey is likely to be. I just want to make something about the the centres that are there, and you may be getting treated in another hospital, but the doctors in this room are the NET experts in Ireland. These are the people, and I think hopefully every patient gets an opportunity to have you look at their case somehow or other by referral. It doesn't mean changing their case to one of those hospitals, but they can still be done in their own hospital, but to hopefully get some sort of a comment on their case and help for their own doctor. So with that, I'm going to invite Professor Criostóir O'Sullivan to come up and talk to us about the role of surgery in NETs.
Thanks very much indeed, Mark. It's lovely to see you back in Cork. I think it's quite a few years since you were all last gathered here. Some of us have aged quite a bit since then. Most of you look a lot younger, I have to say. I want to thank, first of all, Mark McDonnell, specifically for his tireless efforts with this group. I think it's a fantastic achievement that we can have a meeting like this every year. I'd like to thank Tommie Gorman, who's a tireless advocate on your behalf and who works a lot behind the scenes to improve the delivery of services for NETS patients in this country. I'd like to thank Professor Ristéard Laoide, because I think that the National Cancer Control Programme has a very important role to play in the management of patients with neuroendocrine tumours, and for him to be here and to show an interest and to support, and there's a lot of support that goes on in the background, is very, very important. I also would like to take the opportunity of remembering a colleague who has gone into retirement, Professor Justin Gagan from St Vincent's Hospital, who many of you have had the pleasure of meeting and whom he's operated on. A fantastic surgeon and an incredibly dedicated surgeon who has operated, I know, on many of you very successfully. And it's a shame that he's not here, even in retirement, because I think his wisdom and his experience in managing neuroendocrine tumours it needs to be stated. He's also been a fantastic colleague over the years, and it's been wonderful to be able to speak with him freely. We're very good friends and remain very good friends, so I wish Justin all the best in his retirement. It's a difficult topic to discuss in a very short space of time. What is the role of surgery, and when is it appropriate? I am going to show some surgical slides. I hope they're not too gory, and they're not meant to be, but it's a way of illustrating what can and can't be done. Is it moving on, Mark? Sorry. Oh, the bottom arrow. I beg your pardon. Sorry. Okay. So Derek has already alluded to this, but surgery certainly is probably the most significant impact, or makes the most significant impact on the treatment and long-term prognosis for patients with neuroendocrine tumours. But it forms only a part of what's a multidisciplinary team approach to this. There are a number of treatment options there. There's somatostatin analogues, as you know. There are local therapies such as radiofrequency ablation or embolization, where you can block off the blood supply to tumours and affect the tumour in that way. Endoscopy is a very useful tool. I mean, a lot of tumours can be treated, small tumours in the stomach or in the duodenum or indeed in the colon can be treated very effectively endoscopically. There are fancy drugs such as everolimus and sunitinib. There are chemotherapeutic drugs, temozolomide and capecitabine, or cisplatin-based drugs. And then, of course, there's PRRT. So where does surgery fit into this paradigm of treatment for patients? Well, as Mark has already alluded to, I think it's very important that every patient who is diagnosed with a neuroendocrine tumour has their case at least discussed once at a multidisciplinary team meeting. So the pathology is looked at, if radiology is important, is looked at, and a decision then made by a team of experts or a team of people who have got an area of interest in this can make a decision as regards how best this patient is treated. Certainly, in terms of cure, surgery removes the tumour. Once the tumour is removed and there's no other tumour there, there are many patients that potentially can be cured. What's the role of surgery? There are a number of roles in neuroendocrine tumours. The removal of the primary tumour, in other words, the site where it is. Many tumours are localised. They are found in a specific location with no evidence of metastatic disease or secondary disease. So removing that tumour is a definitive intervention and can bestow long-term survival or even cure for a patient. An incidentally detected neuroendocrine tumour of the appendix, for example, can be cured by simply doing an appendectomy. There's no long-term follow-up for some of those patients, depending on where the tumour is, the size of the tumour and the grade of the tumour, and I'll come on to that in a minute. Surgery has a role for the treatment of metastatic disease or secondary disease. Many patients will present with disease that is either locally spread to lymph nodes or has got distant spread to the liver or to the lung. And surgery certainly can, in certain circumstances, be employed to remove metastatic disease. Unlike many other cancers of the gastrointestinal tract, debulking surgery or removing a large part of the disease that is present can actually bestow a survival benefit. in many cancers of the gastrointestinal tract, it's almost an all or nothing philosophy. If you can operate, the benefit of operating is when you can remove the tumour completely. But in neuroendocrine tumours, because often the prognosis is much better, debulking the tumour or significantly removing a large part of the tumour can bestow a significant survival benefit. And the benefit is that you're removing a lot of tumour, you're leaving some tumour behind, but there are other modalities then that can effectively deal with the smaller volume of tumour that that patient has. And obviously, surgery can prevent and treat local complications. Not an insignificant number of patients may present acutely, particular patients who've got neuroendocrine tumours of their small intestine. This is an old slide, but it does illustrate that tumours can basically be grouped into localised, meaning that they're confined to the organ where they're arising from. They can be regional, in other words, there may be metastatic spread or secondary spread to local lymph nodes, or they may have distant metastases. And the tumours, as we all know, and as Derek has already indicated, are increasing in frequency and prevalence throughout the Western world. But in particular, tumours that are localised to the site of origin are significantly increasing. And of course, surgery for those particular tumours may be curative. Surgery, as I said, has a role to play, certainly for regional and for distal metastases as well. So I want to just start by illustrating a case. This was a gentleman that I operated many years ago, and this is a CT scan. I appreciate that it's maybe difficult to interpret what's going on here, but this is a slice through the body, and what we're looking at over here, we're looking up through the body like that. What we're looking at here is the liver on the right-hand side, because we're looking up the body. The spleen is over here, and this is the pancreas here, and in the pancreas there's a large mass. So this patient goes on to have a CT scan, an MRI scan, and it appears as though the tumour is confined to that area with some draining lymph nodes as well. An octrio scan is the standard type of staging scan, which now has been surpassed by gallium dotatate PET scanning. But this shows that this is octrio-avid. So there are a number of potential treatment options that you could use. You could use a somatostatin analog. You could send this patient potentially for PRRT. But it's a localized tumour which is resectable, it's removable by surgery. And this is the intraoperative picture. This is a picture of the tumour at the time of surgery. And what you're seeing here is this is the body of the pancreas here, this is the cancer here, this is the spleen here, this is the liver up here, this is the stomach retracted here, and this is the colon here. And this tumour is removable to take en bloc or together with the spleen and to remove all the draining lymph nodes. And this is the surgical bed. The lymph nodes are stripped from the major vessels that are here. The major vessels are still protected. This is the left kidney here. This is the kidney vein, the inferior vena cava, a major vein that drains from the body and the aorta. They're all protected, but the lymph nodes are all cleared from that area. The pathology specimen is examined by our histopathologists, and of course, the ultimate determination of how this patient is going to do is based on the pathology of this tumour. We obviously need a biopsy of the tumour before we start, because it's important that we know whether this tumour potentially will benefit from surgery depending on the aggressiveness of the surgery, the aggressiveness of the tumour itself, in other words, the grading. So this patient has a fairly sizable tumour, and he's got a significant number of lymph nodes involved, 10 out of 13 lymph nodes. It's a PT3 tumour, and this patient will certainly need long-term follow-up scanning for the years to come. But surgical intervention here is the critical intervention to be undertaken. Sorry, Mark. Oh. That patient is still alive and well and disease-free many years after the original diagnosis. So it's the actual biology of the tumour here that to a large extent will determine how that patient will do. Did I do that, Mark, or did that, I don't know, gremlins in the room? Yeah. So, thanks very much indeed, Mark. I mentioned debulking of disease. So this is a patient who had a neuroendocrine tumour of their right colon and had secondary disease to the liver. And again, intervention in the liver is possible to remove secondary disease. And if you can't even remove all of the disease, if it's possible to remove up to 80% of the disease that's in the liver, it bestows a significant survival benefit on the patient. And there are a number of ways that you can deal with metastatic disease to the liver, not just in terms of surgical resection. You can use what's called microwave ablation, so putting needles into the tumour, burning the tumour, so you can spare a lot of the normal liver tissue around the actual tumour itself. I mentioned the spread of secondary disease to lymph nodes, and this is particularly of importance in neuroendocrine tumours of the small intestine. Very frequently, the tumours are very, very small in the small intestine, and the secondary disease can be quite significant to lymph nodes or to the liver. But in particular, the lymph nodes can cause problems in terms of the venous drainage of the tumour itself, and can narrow the venous drainage and cause problems with the bowel. So it's important to intervene here to remove these metastatic, remove these metastases before they actually cause a problem. Sometimes a large amount of small intestine has to be resected or removed because of a nodal mass at the very top of the blood supply to the bowel, because otherwise, over a period of time, this situation can occur, which is an emergency presentation of a patient with a neuroendocrine tumour where the lymph nodes in draining the small intestine have actually blocked off the venous drainage of the small intestine and caused ischemia or a death of the bowel, and the patient, of course, presents acutely to the emergency department very unwell and needs emergency surgery. What determines operability? There are a number of factors here when you're considering operating on a patient. Obviously, the condition of a patient. The patient needs to be fit enough to undergo the operation. The patient needs to be in the best possible condition going to surgery that you can get them into. And this is particularly relevant for patients who, for example, Derek has mentioned already carcinoid syndrome, that these patients are well controlled before they come to theatre. The localization of the tumour is also important because it determines not only, number one, whether it can be removed, is it in relationship to very important critical structures that can be preserved, and number two, the extent of the operation that you're going to undertake. You try to take the minimum tissue that's required, obviously, but you need to ensure that you resect the tumour completely. The stage and the grading of the tumour are important. Derek mentioned very briefly G1, G2 and G3 tumours, depending on the number of cells on the biopsies that are replicating. G1 and G2 tumours tend to be of lower grade and slower growing than G3, broadly speaking. And G3 tumours, generally speaking, are better treated with chemotherapy as opposed with surgery. It's important to know whether the tumours are functioning or non-functioning. Insulinomas, for example, may be very, very small tumours but have a significant impact on the patient. Neuroendocrine tumours of the small intestine that are secreting serotonin, the patient may need to be controlled before coming to surgery. And of course, the other issue then is, are there other modalities that are equally as effective rather than surgery? A small neuroendocrine tumour of the stomach, for example, a G1 neuroendocrine tumour or a type 1 gastric carcinoid tumour may very effectively be treated with an endoscope as opposed to with a surgical operation. Equally, a neuroendocrine tumour of the bowel, if it's small, it may be treated endoscopically, so with a colonoscopy, as opposed to having the entire bowel resected. And I said the condition of the patient, this was a patient of mine who had carcinoid syndrome and had to undergo right-sided valve replacement before we could actually take him to theatre. He had carcinoid syndrome, classic flushing, diarrhea and bronchospasm. The heart needed to be controlled, and obviously he was on an octreotide infusion before his primary tumour was removed. Small tumours of the pancreas, for example, an insulinoma, the location of the tumour is also very important because it will determine the extent of the surgery that you undertake. And what's critical in this particular situation is there are different treatment options that are open to the surgeon potentially to remove this tumour. It's only 1.5 centimetres. It's a very small tumour in the pancreas. Do you enucleate it? In other words, just take that little piece of pancreas out with a little bit of normal pancreas around it. That's all that really needs to be done. Do you remove the middle part of the pancreas here, or do you remove the body and tail of the pancreas? And much of this is dependent on the relationship of that tumour to the pancreatic duct, the proximity to the pancreatic duct, because if you end up with a hole in the pancreatic duct, it can lead to significant complications post-operatively. And that is established with MRI scan before surgery, with endoscopic ultrasound done by the gastroenterologist such as Dermot O'Toole, or in theatre with, as you can see on the left-hand side here, with an ultrasound scan. And what you're trying to do is determine the relationship of the tumour itself to the main pancreatic duct. And this is the pathology specimen here, and shows the tumour. This is the round insulinoma tumour and its relationship to the pancreatic duct. So in this case, the pancreas had to be resected because of the proximity to the duct itself. You can't just shell this out, because if you shell it out, you'll cause an injury to the pancreatic duct, a pancreatic fistula, and problems for the patient post-operatively. I mentioned this is not, this is a very basic slide in terms of grading. It's not the most recent, but what I want to basically demonstrate here, again, is the grading of the tumour is really very important. G1 tumours and G2 tumours that are well differentiated tend to be cases that are well treated with surgery, whereas poorly differentiated tumours, generally speaking, are better treated with chemotherapy. Finally, the extent of metastatic disease is very important. There is no point in going in aggressively to go after a primary tumour if the patient has got widespread metastatic disease, unless you're doing it to alleviate an obstruction or so on. This patient, for example, has got evidence of widespread metastatic disease to the small intestine, the lining of the small intestine. The prognosis from this is not particularly good, and doing extensive liver surgery in the presence of disease like this will not ultimately, or is very unlikely ultimately, to benefit the patient. And equally, a patient who here has got a dotatate PET scan done, which shows widespread metastatic disease in the body, isn't going to benefit from a palliative resection of some secondaries in the liver. So the extent of the metastatic disease must inform the surgeon whether this is going to be of benefit to the patient or not. So in summary, poorly differentiated neuroendocrine tumours are generally speaking, not exclusively, but generally speaking, better treated with chemotherapy. Surgical excision is the only curative treatment for well-differentiated NETs, G1 and G2. The goals of surgery should be to prolong survival by resecting the primary tumour, potentially curing the patient, and dealing with the nodal or the secondary disease in either the liver or the lung, to control the symptoms of hormone secretion, such as, for example, in an insulinoma or a patient who's got carcinoid syndrome with a small bowel neuroendocrine tumour, and to prevent local or to treat complications such as bleeding, bowel obstruction, or as I demonstrated here, where the patient can end up with ischemic or dead bowel as a consequence of the nodal metastasis in the small bowel mesentery. That's it. Thank you.
So, thanks so much to Criostóir for that fantastic talk. I'm sure, like you, I'm always amazed at what surgeons can do and what they do for us. So with that, I'm going to invite Dr. Hussein Almeamar to come up and talk to us about advanced therapies.
Okay, thank you. Thanks a lot, Mark. And thank you all for attending today. It's good to see you. And thanks for organizing this meeting here in Cork. My topic today is about targeted therapy. And I thought this, is a bit of medical terms, but we do mention these terms, we do mention these therapies when you come to the clinic. So it's good to explain it and try to explain it in a simple way. So, sorry. Right. So what targeted therapy mean? If you look at your at your net tumor, it's made of small cells, these little circles, right? And if you look at your neuroendocrine tumor cell, we know it has few targets, few proteins. And these proteins, if we target them, they are going to suppress the growth of these cells. And by this will suppress the growth of your tumor. And whether you take the treatment as an oral, as a tablet, or whether you take it as an injection, or whether you take it in the vein as a drip, we know it's going to directly go to these targets and it's going to suppress the growth of your tumor. So this is what we mean by targeted therapy. There are a few examples of them. I don't want to bore you with the name of the targets, but the monthly injection, the PRRT, the everolimus, sunitinib, all these treatments that some of you already on or tried are examples of targeted therapy. I'll focus today on PRRT, and I thought the best way to talk about this is try to address the common question that you might ask, or patients usually ask when they come to the clinic is, what is PRRT? Why PRRT? When to have PRRT? Where to have PRRT? And how to get PRRT? Right, so what is PRRT? PRRT is short for peptide receptor radionuclide therapy. Again, these are all medical terms. And the easy way of explaining that, so the first two, peptide receptor, what does that mean? Is a simple way of explaining that it's like a key and a lock. So we have the target, as I explained in the previous slide, and you want to target this by giving a specific key. And then you have a keychain where you attach a radiation to it. And we use this principle for diagnosis when you have your scan, like the gallium PET scan, which is exactly the same target, the same key, and then we attach a simple radium that will not kill the tumor cell, but will be enough for the camera to see the tumors. And you see all these hot areas, the black areas are the tumors. And then when you go for PRRT, it's basically the same principle, exactly the same key, the same target. It just the keychain a little bit different, with a bit of a stronger radiation that will go to the tumor cells and kill them. So it makes sense if you have the PET, the gallium PET, if we know that the key already went to the target, we saw them by the camera, that makes sense. When we give you the PRRT as a treatment in your veins, it's going to attack the tumor and kill the cells. Why PRRT? So any treatment for any disease or any cancer, you need two things. You need data to support why we are doing this treatment, and you need experience. And the journey of PRRT has been a long journey, and you might be surprised. It's been more than 20 years journey. Started in the 90s, where with the radiation they use, the radium they use. At that time, it was the indium, the yttrium, then in the 2000, the lutetium. And it's going through phases of studies, of research, what we call them clinical trials, as Dr. Power mentioned to you earlier. And to reach a final stage, or to have a strong data to support the use of that, we call it phase 3 data, right? And they managed to reach that in end of 2016, beginning of 2017, when we had the data to support the use of PRRT in neuroendocrine tumors. And this journey is a long journey, and as a patient, I suppose it's very important, as Dr. Power explained, being part of research and clinical trials, because without the patients who were part of this 20 years journey, we wouldn't be here today with PRRT. So it's very important to advocate for that as a patient group. Clinical experience, we have our own experience. We publish this data in Dublin for patients who went for PRRT. And we know, with our experience, it was effective in around 90% of patients. It's managed to give the patient stability of disease of an average of 3 years and very low side effect profile. However, there are some serious rare side effects with PRRT. Some of you are aware, like leukemias. So it's very important then to go to the next question about when to give the PRRT. And some of you might ask, why don't I get PRRT, for example, in the early beginning of the diagnosis? And some of you might ask, when we mention PRRT as an option, why now? Why not wait a little bit more? So it's all about giving the treatment in the right time. And as Dr. Power explained, and Professor O'Sullivan, the multidisciplinary team, the tumor board, and this is in the National Centre in Dublin, and also in the NES Centre in Cork and Galway. Your case will be discussed at these tumor boards, and decisions made about when to give the treatment. Professor O'Toole will explain about the National NET Centre, which we receive referral from all the hospitals in Ireland, and this is coordinated with your centres and with the other centres in Cork and Galway, where we send patients for PRRT for Uppsala, London, or Rotterdam. We looked at the number, we audited the number of patients who went for PRRT, and as you can see from the curve, very obvious increase in the number of referrals. There was a waiting, of course, getting a treatment abroad, an average of 3 months, and obviously this is frustrating for patients, and unfortunately we lost a few patients. They were waited for PRRT and it was too late, and they couldn't make it. And this is the last figure from last year. The numbers are even more. So this obviously necessitates the need for establishment of PRRT here in Ireland. And this is with your voice as an advocacy group, with the great support from NCCP. Professor Ristéard is here, and the leadership of the National NET program, Professor Dermot O'Toole. We got the funding and the setup of the PRRT treatment center in Dublin, St. Vincent University Hospital. This is a picture of the treatment room where you'll be in a recliner chair, and this is how you'll get the PRRT as a drip. Some of you already had this experience going abroad, and you can see all these screens to protect the staff looking after you from radiation. And the whole thing will take around 4 hours, where you'll be allowed to drink and eat. You can go to the toilet, etc. And then there is also beds where you'll be staying overnight. And there's also what we call them dosimetry or therapy scans. Setting up all of these obviously took some time, and apologies for the delay. I know you've been waiting for that. And Professor O'Toole will, in his talk, will mention to you about our early phase, or initial phase, if you like, starting with this treatment, and how we are going forward to try to accommodate all the patients here in Dublin. And finally, just to tell you a little bit about the setup, we appointed 2 nurse specialists who will be looking after you, and also will help to look after NET in general. We set up another specialized tumor board, or MDT, which will be linked and coordinated with the centers and your NET specialists in Cork and Galway. And this is the protocol, the journey, which is pretty much the same as the protocol abroad. Some of you already have the experience with that. We set up a new clinic where you sit down with your NET consultant and the nurses. There's also the nuclear medicine team that will do assessment to you, the nuclear medicine specialist. And there are a lot of scans, the usual CT, MRI scans, and the therapy scans. And it's a long journey. It's almost a year. You'll be linked with the PRRT service until you'll finish. With that, I hope I address all the potential questions. And thank you. Thanks a lot.
So thank you very, very much, Hussein, for that. And I think we're all excited at the possibility of PRRT in Ireland, and I know we'll hear more from Professor O'Toole. So I'm going to thank the 3 speakers for the first part of our sessions, and you can sit down out of the limelight if you want now, and invite Professor Ristéard, the head of the NCCP, which is the National Cancer Control Programme, and they control everything to do with cancer service delivery in Ireland, and Professor Dermot O'Toole, who's the national lead for neuroendocrine tumours in Ireland. So if you could take your seats up here, and I think we'll be joined hopefully shortly by Micheál Martin, who will also address us. So we'll start off this session by getting an update on what is happening with nets in Ireland by Professor O'Toole. So if you, sorry, you want to come over and restart this? It's down to start.
Thank you. Good morning, everybody. Actually, some of the talk was to be addressed to on Tánaiste, so it was, I'm not sure of the timing. How are you keeping? Ballincollig, first time I was here. It's lovely. It's great to see you all. Thanks for coming. I hope you're all keeping well. Some of you, we've discussed this before, what's a centre of excellence? It's a difficult one to really sort of address in a sense, because you could take it as a tongue-in-cheek, how are we excellent at all, And what we're trying to do is strive towards some form of excellence always. And in any system, and I think that if we were Dutch or if we were French, whatever, we're always subpar, you're always trying to get right to the pinnacle so that we can do the best by you. If we do the best by you, we're happier. Derek and Chris and Hussein and Ristéard, everybody. And I think the leads as well in the patient group, we all want to be better and improve. But there are little inadequacies that crop up. And I suppose over time, trying to get towards a platform where we can do our absolute best is what we're all aiming to achieve. And that word excellence was coined a number of years ago, mainly around cancer centres emanating from North America and some very big ones in Europe as well. So I want to give you sort of a sense of what that is. I was part of a thing called the European Neuroendocrine Tumour Society. And I personally think, and I'm convinced of it, that since 1998, that this has been the most important thing that has changed Irish neuroendocrine tumour patients' lives, and many of them around the world. It's a benevolent group, initially set up by 7 people, like-minded, who had an interest in neuroendocrine tumours across Europe, from France, from the UK, from Germany, Italy, Spain. No, there wasn't actually a Spanish one at the start. But anyway, there was a further group, and they got together and they went for a few meetings. And it wasn't sort of going to a meeting and having a junket and nice meals in a big hotel and all the rest of it, because they had no sponsorship at the time. They were just interested. So they paid out of their own pocket to come together, and they created what was to lead to the Neuroendocrine Tumour Society, European Neuroendocrine Tumour Society. So benevolent, given their own time. And it led actually to bringing together these teams to formulate ideas, concepts, share their patient experiences about carcinoid syndrome, about the treatment, the surgery, and all the rest of it over time. And with that mushroomed into the creation of a strong group that was really well supported to aid this whole process, and became a very sophisticated thing. And that led to then similar developments in North America with a thing called NANETS, the North American Tumour Society, Canadian Tumour Society, Asia Pacific Tumour Society, etc. And it led eventually then also to patient groups, because the patient groups followed from that when there was an organised physician group. Patients groups started in different countries, and that then mushroomed to the Net Patient Network, and then to the INCA, the International Cancer Alliance, which represents the patient groups on a worldwide basis. In fact, it's a very important structure, and maybe we'll touch on that a little bit later. Mark, I'm not sure if you're talking about INCA, but as Derek really nicely alluded to, please, I don't see the need to create further pamphlets of information, etc., because I give you and your booklet the INCA website, and you go to that and you download that, and it's really well done. And a lot of us have participated in the elaboration of leaflets and information, etc., that are on those sites. So please. Well, I thought the reason why I thought talking about the Centre of Excellence would be good, because that would enlighten him a little bit more about it. Perfect.
I do want Micheál Martin to hear what Dermot has to say, and it is important. And I don't know where Tommie is, so I'm not sure what the status of that is. But I'll talk a little bit about INCA. You have heard of it. It's been mentioned this morning. Some of you may not be aware of it, but INCA is called the International Neuroendocrine Cancer Alliance. It's a global umbrella organization of patient groups. We are, I think it's currently 34 member organizations from the 6 continents. We in Ireland Net Patient Network are part of it, and I myself am the current president of INCA. I finish up as that role in March next year. Again, INCA, like Net Patient Network, is voluntary. All of the people there's 2 paid staff members, an executive director and a project officer. And the rest of all the activities is done by volunteers from across the world. And ENETs have been really, really helpful and partner with INCA, with us. Dermot is the former president of INCA. Sorry? ENETs, sorry, ENETs. Not INCA, ENETs. And Dermot was very instrumental in bringing in patient engagement in ENETs. As INCA, we run so many different projects, but the Net Cancer Day, November 10th, that you have all know about and heard of, that is a creation of INCA's. They looked at the calendar and picked November, and then November 10th has been a day to celebrate and to raise awareness. And we have been really, it's built and grown enormously. I think the first event of that was, I think, around 2011. And now Net Cancer Day is used by so many organisations not associated with INCA to raise awareness of this disease. For the last 3 or 4 years now, ENETs and INCA have had a joint webinar. We had one on November 10th just gone. It's online, available to view if you want. I think it was probably the best one we've had so far. We had some introductory talks, but the main format was panel discussions of patients and doctors and taking questions online. So it's up there. It's over 2 hours, but it's really, really great to get some more information about the disease and what's happening. And there was a section on diagnostics and treatments. There was a section on genetic nets, section on what's coming down the tracks. So worth looking at, and that's on the enets.org website, and you can also find it on the INCAalliance.org website. One of the projects that we're working on in INCA at the moment is called SCAN. It's Think NENS, and it's a derivative of SCAN. SCAN was a survey that we did in 2019. We had over 120 Irish patients responded to that survey, and in doing that, it exposed a lot of information that we probably already knew, but I mean, to give some flavors of that, it's on average across the globe 5 years before a patient receives their correct diagnosis. So obviously that means that in most cases that the disease has progressed. And 42% of patients, by the time they got their diagnosis, were stage 4 with distant metastases. And that, that means that, it can't be cured, so it has to be treated. Other information that came out of that was, I think it was 20% of patients saw 2 or more consultants before their diagnosis, and another 20-something% saw 4 or more consultants. And I know my own journey replicates that in so many ways. I had my first potential issues in 2002, and I got my diagnosis in 2011, having seen multiple consultants along the way. So out of that SCAN survey, INCA decided to try to raise awareness amongst general practitioners, because SCAN revealed that the problem is lack of information. The symptoms can be quite vague, so GPs are referring patients for IBS or gastritis, sometimes even anxiety. So we want to raise awareness of patients, of general practitioners about the disease, and we're running a program called Think NENS, and Dermot O'Toole is instrumental in leading that for INCA, and it's an educational program for general practitioners. It'll be released next year, and we'll do our best to try and make get Irish general practitioners to use this program. They'll get continuing medical education points from it, so that's another program that Inca does. So, you know, have a look at the Inca website, have a look at the ENETS website. There's some amazing information there. Eoin will talk a little bit about our new website, which is integrated with Inca's, and that is a great source of information. So, I want to welcome Micheál Martin for coming here. Thanks so much. And now I'm going to hand back to Professor O'Toole to continue his presentation.
Thanks, Mark. So that's really amazing to have on Tánaiste. The last time that on Tánaiste and I met, we were at a similar type event, but in a different sort of format. And I was honoured to be asked by Tommie to launch the book with on Tánaiste, and it was a great pleasure. But I was talking, and I'd read his book. Of course, there was a lot of reference to Micheál Martin in a different role at the time. You were Taoiseach at that time, and you were Minister for Foreign Affairs of the North as well. And it was really fascinating to read about that. Can I just say, on a personal, but I think also representing our national group here, that what you've just come back from Israel, I know, because we're following what you're doing very closely. I think we're extremely proud of Ireland's voice as being the first contributor to castigate atrocities on both sides of this current conflict. And I think that you and the Taoiseach have been absolutely marvellous with that in mind, and you were out on a little bit of a limb, I think, at the start, and then the next day the UN went and the same thing, and now we have a unified voice throughout Europe, and it hasn't been easy for you, very troubled waters, but I'd just like to acknowledge the great work that you've been doing, both internationally and getting our Irish people back. Thank you. So this is our group, on Tánaiste, patients and families with neuroendocrine tumours. The group that's been led by Tommie and Mark has been in existence for 11 years. It started in Cork, in your native parish, let's say, with Criostóir inviting, in fact, the group down initially. And it's fitting that we're back here today to welcome you in your own county as well, to have a chat about the neuroendocrine tumour group. And we're just going to give you a little bit of background about where we've come to in the journey. So, and we're talking about what is a centre of excellence. Well, a centre of excellence, of course, can be many things, but what we try to be is try to be as good as we possibly can. A centre of excellence then has emanated from a European Neuroendocrine Tumour Society, a group of like-minded people benevolently getting together to share ideas and concepts way back in the early noughties about patients with neuroendocrine tumours. And what happened was that this grew over years, really based on forming guidelines and society then in 2008, 2009 had a working group that set up to create a centre of excellence model. And it's one of the first, and it is actually the first pan-European. So we've got centre of excellence, like I mentioned to you a little bit earlier, in North America, where you would have people looking after breast cancer. You have a big breast cancer group with all the interested physicians and the radiologists and all the rest of it. But this concept was to actually have people working in London, in Rome, in Paris, and smaller places. I'm taking out the capitals that we all know, but to be all working in a harmonious way, looking at the same diagnostic tests, the same therapy pathways, etc., and how the whole thing evolved was around that. And it's got to do with, and I'll just go through this slide, accreditation and certification. There are methods to ensure quality by setting standards and following robust and transparent processes. There are standards that help the patient to identify high-value service and therapy options, Healthcare professionals benefit also from increased recognition and ongoing improvements in their service. In 2008 then, we set up an accreditation process and certification program which allows centres throughout Europe at the time to apply to display competence and expertise in a multidisciplinary team, knowledge about and adherence to the guidelines that we produced, and patient-oriented care, increased participation in clinical trials, and establish a systematic approach for collaborative continuous improvement and benchmark system for the participating centres. So it was to improve quality right across the board, with you as the primary interest and the primary focus. And once again, we had support, of course, from some pharma outside, but we had to create a lot of our own funding, and it was completely benevolent, and it remains to this day. I was very honoured to ask to chair this group, and it's probably the singular and most important thing that I've done in my medical career to date, I think, because it's worked very well. In Ireland then, what happened was, in about 2007, I suppose the journey started with a few interested parties. Is Donald here, by the way? Donald O'Shea? He's not here yet, all right. And Tommie and Donald, that's what I say at the start, ring fencing and sort of trying to corral a few people together to get, you know, a similar little mini ENETs in Ireland. We formalised a sort of an agreement that wasn't written down in 2008. And then through the NCCP, the National Cancer Control Programme, and of course Ristéard is here as the lead now, currently. At the time it was Tom Keane from Canada, and set up NCCP. Gosh, I often think it's not well funded enough, because NCCP has been a really important thing in Ireland by establishing the cancer groups. You remember back in the bad old days, you could have breast cancer in any little hospital in Ireland, and that's fine. Of course, people sort of were fighting to hold on to their cancer care in small hospitals, but colorectal cancer, breast cancer, and the rarer cancers like pancreatic cancer, going to designated centres, esophageal and gastric cancer, all of that now being done in what we call, Centre of Excellence model groups, has really transformed cancer care in Ireland. Derek, I think, is one of the lead oncologists in Ireland. Derek, you'd agree to that, of course. And, while it's hard that your hospital I know, take an example, somewhere, a smaller hospital, that you can't do that, you've got to go a bit further. Ultimately, the benefit, of course, or the gain was for individual patients, and that's what it was aimed at. So we, within the NCCP then, we created a structure, and we got initial accreditation in 2015 and 16, and we were affiliated in Vincent's as an ENET Centre of Excellence. It's quite a lot of work. What it involves is that we have to analyse our data every single year and send it back online. We have physical audits then when international experts come and look at what we do. So they will look at patient files, they'll sometimes interview patients in the outpatient clinic as well, etc., to see, are we actually operating to a sufficiently high level to merit that accreditation status. And the ambition, of course, become proficient in providing Irish patients a high standard of care in the NET field. So this was just our little journey, and some of the names at the first meeting. You can see Tom Keane here, but Tony Hula and Donald and Criostóir, of course, was there as well at the initial meeting way back then, and just to acknowledge Criostóir and the great work that they've been doing here as well. So these were sort of the concepts around that, and in 2012 we nominated an Irish group lead, and then formalising a network. And down the line then, we got to the state where we were in a position to have lead endocrinologist, gastroenterologist, oncologist, radiology, pathology, nuclear medicine, surgery, and pulmonary expertise. It's just to name a few, because you also have to have palliative care involved. You have to have pain control. You have to have cardiothoracic. Criostóir was talking about somebody having, maybe it's rare, but you have carcinoid heart disease. So you need a good quality cardiologists who know about that. You've got to teach them and bring them on. Cardiac surgeons, if you have to have a valve replaced, etc., etc. So it's quite a big team involved. And for a rare tumour type still, to get the interest of all the parties it's not that easy, I must say. But more importantly, I think you have to have all of this structure. You see, you have to have an organizational management structure. You have to have the multidisciplinary team meetings. We call that the tumour board, where all of those people that I showed you earlier, they're there to discuss. And we debate what sort of treatment is the most appropriate at this given time for individuals. We're talking about individualizing therapy for different patients. Quality management, we have to see how we perform in that. And the consultation. So the consultation, for example, is a multidisciplinary process. So we try to, if you're coming and there's a surgical question, for example, hypothetically, Criostóir and I would be in the consultation on a Friday morning, and if I felt that one of us needed to have a surgical opinion, well, you know, on the same day you can have a surgical opinion, you can have an endocrinology opinion, you can have an opinion for nuclear medicine, because Hussein is not a nuclear medicine physician, but is leading the nuclear medicine program in our centre now. So if you're coming for a nuclear medicine, a PRT a question, you might see me in the morning and then just straight away afterwards see Hussein then to discuss the nuclear therapy option, the PRT, which is nice that we have that capacity to do that. Scientific activities, how do we perform in terms of data? Hussein showed you a publication that I'll just allude to in a moment, so we're trying to increase that as well, both basic scientific research, but also the clinical audit and outcome of what we do. You know, are we up to standard? Are we sufficiently good? And I'd like also to be much more proactive in prospective clinical trials. Now, you know, we've had Mark Doherty appointed half-time oncologist in neuroendocrine consumer. We hope that Mark will take on the clinical trials, and Derek's swamped with so many other different things as well. But we'd like to have that more available to you as well going down the line. Follow-up and documentations are important aspects as well. So now there's over 75, actually that's a little bit old, but since 2009, there's been 70 odd, let's say, centres of excellence that are ENA accredited, both in Europe, also in Australia and United States. And we're proud to be one of them as well. And I think that's, we're on the map, and we have been for a while. That's the logo that we have, the Centre of Excellence benchmark, as it were. So what's done then? All new patients, then we try to discuss patients within 2 weeks of referral. It's not always, it might be a little bit, but we usually get that pretty good at the dedicated multidisciplinary team meeting, which is every second Friday. We have 2 a month or sometimes 3 a month if it's a long month. And then they're seen in the multidisciplinary clinic after that. The vast majorities of therapies now are available to us, and if they're not available, there are some very rare treatments that will never be available in Ireland because it's just so rare that doesn't make financial sense to set it up. That's why we have the treatment abroad scheme, and that's been so supportive through Catherine Donoghue and our colleagues down through the years for the PRT, but for other things as well, when we were sending patients abroad for gallium PET-CT scans, or sophisticated scanning, and many other things. But we can send a patient abroad for an opinion. We've got radiofrequency ablation now through endoscopic ultrasound that might be useful for certain tumours of the pancreas in certain individuals. We don't have that at the moment, but we'll try to get that. But you know, in the meantime, if we needed to, maybe we can send somebody to Rome or to Rotterdam or wherever. And that's been invaluable as well. And the Centre of Excellence model means that we can communicate with partners within that group to give opinions, to do tests, and to perform therapies if required as well. So we've about 200 patients per year now, roughly, maybe a little bit more this year. And the team has had to grow over that time with, like I said, a new oncologist and a new net physician, which I was delighted to say was Hussein has been doing absolutely superb work. And we've had this ongoing audit, review and revision. That's what it's about. When it comes to the nuclear medicine, then we've got the diagnostics, and Mark mentioned gallium PET-CT scan that has replaced octreotide scan. Some of you sometimes now still might have an octreotide scan or a tetrodoid scan because the waiting list is a little bit long for gallium PET-CT. Gallium is a very sensitive nuclear medicine screening apparatus that we want for most patients, not every patient. Like the little small ones in the gastric, for example, they don't need to be done. But for most people with a small bowel tumour or pancreatic tumour before surgery, that we'd like to have a gallium PET-CT before making a definitive decision on treatment. And there's a lot of patients now that we have, they've come out from the woodwork, so there's a big demand on it. There's one in James's that doesn't do an awful lot of our patients, to be honest with you, but we've one also in Vincent's, and there's a big demand on that, and we don't have enough staff. And we've been trying desperately to improve capacity, really desperately. And Ristéard, the head of the NCCP, has also facilitated a special process where we can try to have that more automated. The Vincent's group got support from Ristéard and his team with that, and we're really grateful for that. That will improve things as well. But ultimately, we would see that setting up another gallium generator and scan would be excellent, and maybe one south of the border. It would be good. Down here would be great to have it because we've got a big catchment area from Limerick, Waterford, Kerry. We can talk about that again at the meeting. But anyhow, it's really important that we have that. That's one of our deficits. We'll talk about that, maybe the questions and answers. The other thing then, is, as Hussein mentioned too, and addressed, was the PORT. And Hussein, I have to congratulate you because Hussein was the person who did the first treatment actually just a couple of weeks ago. So all of the patients were going to Uppsala or to Rotterdam, or a few patients were going to the UK, and we've now successfully treated our first patient, and we've got a number lined up to take that process forward. There are some of you in the room maybe will need PORT, or maybe you're having PORT at the moment. You'd have to be a little bit patient because, of course, we want to do it in a proper way, in a safe way, and we have to build it up gradually over the next, I would say, year and a half. So we're still going to ask patients, and we've spoken to Mark and the Tommie and the group, we're still going to ask patients to go abroad, especially the fit patients, etc. And we'll be trying to increase capacity over a period of time. And that's sort of that's been facilitated by Catherine Donoghue and her group as well, allowing us to continue the treatment abroad access, which is really important. Similarly, I think there was a question on CAR T cells we'll talk about later, but that's a sort of a fancy treatment for leukemias and lymphomas. But similarly, there have been lots of other sort of rare treatments that have had to phase in coming on board in Ireland while patients are still going abroad. So we can talk about that. But and well done, Hussein, everything went well. And he mentioned about, patients coming from a little bit further, staying overnight, because you have to have after you have had your PRT treatment, this is a radioactive substance, of course, and there are regulations that we have to abide by, and we can mention that later on. But then we want to see that we want to do what was a special scan called a dosimetry. It's a nuclear medicine scan again. We want to measure what's gone into your tumor cells, but also what's gone into your kidneys, your bone marrow, or your other organs, so we can calculate what dose is actually safe for you down the line as well. We want to be able to do that in a nice way, and we're able to manage that for patients coming from around Ireland. So that's a good update, and we're very happy to be there. So we have the dedicated expertise, of course, and getting PRT going has been really instrumental. I don't know where this came from, whether the background, Ristéard, but yeah, I'm sure there's a story, all right. Look at the NCP from the start, from Tom Keane right back at the first time, and Tommy, you'll remember that, our first meetings, then we had Susan O'Reilly, and we had other iterations. But this man gets it. He gets the, you have a business plan, you've got a good idea, you've got something that's sort of working already, patients are going abroad, and a lot of our patients were coming to us and saying, but they're happy going to Uppsala or going to Rotterdam. And Derek and Criostóir were sending patients to Rotterdam for years and years. Now, the Rotterdam access closed down for reasons that I won't get into, but nothing to do with the Irish patients going over there. They had problems with their drug and access and all the rest of it, and financing that. So they weren't treating people from abroad. Uppsala, fortunately, was still able to go, and they were wonderful to us and wonderful partners. And I'd like to thank them really from the bottom of my heart for all of the treatments that patients have got from this country. But there were certain patients who couldn't go, certain patients who didn't want to go. During COVID, I had two colleagues, medical colleagues, one of them a close friend of mine, who was soldiering over after just the first phase of COVID in lonely airports, nobody in the airports, scared out of her wits, going to Uppsala, like 2 or 3 flights at the time because it was in the middle of winter. Well, it was early spring, late winter. And I think that there had been some, interest in trying to repatriate this treatment to Ireland, but Professor Laoide, really, you were absolutely superb, and you backed that 100%, and I really, really thank you for that, honestly. Thank you. And there's been a lot of meetings back and forth, and the NCCP were really good in terms of helping us and helping us finance it, but structured as well. And through Stephen Skean here, one of my colleagues in radiology and nuclear medicine, and he chaired the local sort of implementation of that within Vincent's, and that's been really marvelous, and we're very happy to get to this level. So the reason why it's important is, of course, that now Hussein has showed you this, but 90% of patients have tumour control in the right area. But just also to remember, because it all seems a bit rosy, that up to 10% have progressive disease, and despite the PRT. I don't want to leave you with a negative note, but neuroendocrine tumors, people can live for a long time, but there's a sufficient number as well who don't, and it's aggressive disease. So progress is still needed. And that's why having multidisciplinary groups, like in Cork, like in Galway, like in Vincent's in Dublin, and getting to see the multidisciplinary groups is really important. So as a Centre of Excellence then, this is just really updated. This is just really recently been published. New guidelines and new standards are there, and we have to live by those, and we're updating all of the time. That's really, really important. We also have, through, again, NCCP-led initiative, very good as well, we have the national leads in oncology. So I think the concept, and you can mention this, of course, Ristéard, but the concept that I understand is that, all the different cancers have national leads so that we can communicate as clinicians within it to feedback to the NCCP. So there's good communication and dialogue. And we have one in the neuroendocrine tumor, fairly recently set up. And this is NCCP governance with Cork, Galway and Vincent's, of course, and we have different representation on that, which is great. It's been helpful for us to iron out potential problems for the treatment for the PRT, but other issues going down the line, talking about gallium PET-CT and hopefully supporting a bid from Cork, for example, to have gallium, etc. So this really is helpful for us going forward. Future directives then, just very briefly, Hussein also set up what's called the ENETS database that we have now running, and some of you will be in the clinic. You'll have a big form, which is GDPR. We have to fill out this big form to allow you to have your data entered anonymously, of course, into a database, if you're willing to do that, so that we can have data collected prospectively for Irish patients, maybe even retrospectively. That will also allow us to participate in retrospective clinical trials where, for rare tumours, of course, the more people analyse, the better. GDPR, by the way, has got a bit mad in this country, and it really has, in my opinion, sort of stumbled a lot of progress in research, and there's been a lot of debate about that, and I might come back to you, the patients group, to sort of lobby on our behalf, because it's become a bit crazy. I think it's been overinterpreted, basically, as opposed to other countries, but that's very good, and again, great initiative by Hussein in establishing that. So let me give you an example. MEN1 patients, multiple endocrine neoplasia, this genetic inherited disorder, very few patients overall in Ireland. We have 30 families that we know of around that, okay? Now there are more, but thing is, with 30 families you can't get much analysis, but if you put 30 families there, 60 families in Holland, 120 families in Germany, and you see the way it mushrooms, and then you're gathering the data, it just makes an awful lot more sense. Just as an example. And that's the platform to participate in meaningful trials. We're still improving. I mentioned, of course, that there are some things that we discussed later on. Support staff for some of the centres, maybe in Cork as well. Improved gallium PET-CT waiting times, etc. But this is the concept. It's talking about, as we increase the numbers, we also want to get good quality output, audit and analysis, contact with other partners, regular updates, research and development, ongoing training. That's an important one. And if you're a big unit, you attract very good quality junior people as well. So it's competitive as well, very important. And then that's what we're doing today, interaction with the Net Patient Network and INCA that we're heavily involved in. And that allows us to do that as well. Second last slide. Does Centre of Excellence impact on how patients, are you going to live longer? It's a good question, isn't it? And it's hard to actually analyze that. And there's anecdotal evidence in the past that it works, but this is good. 2003 data showing that the red line in the top, this is cumulative survival. There was a definite significance improvement in Centre of Excellence, since Centre of Excellence care pathways were established. And they tried to balance that out and weigh that out against other cofactors, okay, in terms of disease stage, etc. So that's from a group in Norway. This is our friends in the UK, no longer in Europe, but they're still publishing. We have here, the black bar this is time periods. These lines here, the vertical lines are time periods, 3 time periods, right? I can't really see it now. 1995 to 2002, 2003 to 2010, and then the last period up to 2018. And this is the one here, the black. Startling survival advantages, okay, since Centre of Excellence model has been involved. It makes sense to me, I mean, if you don't go to a Centre of Excellence, you're being offered maybe 1 or 2 treatments and that's it. well, that's not enough, really. So but it is hard to accurately measure that, I have to say. So this is the team that we have, with, of course, our partners, National Cancer Control Programme. We have our coordinators, of course, and I have to shout out to them, the nurses and the coordinators who do a lot of work behind the scenes. And we have to increase this, and we have done with some of the PRT nurses, etc. And I don't have all of the people in. I need to update this slide. National Patient Network, of course, our partners in Cork and Galway, and we've been friends for a long, long time. We want to help them as much as Pat. This pal here as well. It's hard to get a photo of Tommie where he's actually smiling, but I managed. And then this other pal here as well, and all of you as well, so that's really important. Finally then, I've been doing this now since, well, I suppose 2007, looking after NET patients, and there's quite a few of them that have passed on, and a lot of them became friends of mine over time. And, just a few seconds thought for those who are no longer with us. So in my opinion, the Centre of Excellence established by the ENETS model has really had an enormous contribution to improvements in life expectancy. But not only that, also in trying to improve quality of life, because there are so many different aspects that I didn't get to cover today in terms of quality of life and other issues, of course, daily living. Derek touched on it, survivorship, so important, and there are many little aspects of that as well. We had a patient questionnaire there over the last year as well. It was very interesting to look at that and to analyse that. We might share that with you another time. So just to say that, the guidelines and management net and establishment of a Centre of Excellence model is very important. Thank you, Mark.
So, thanks so much, Dermot, for what's happening in Ireland, and I think that the Centre of Excellence model, we are all benefiting from that. I think, what Dermot mentioned there, the first patient to be treated with PRRT in Ireland is a major milestone, and we really should acknowledge that. And, thanks to Hussein and Dermot for doing that. And also, we have a wonderful national lead for neuroendocrine tumours in Professor Dermot O'Toole, who's a very well-respected, internationally well-known NET expert, and as a former president of ENETS, and instrumental in setting up the whole Centre of Excellence system across Europe and the world. So, thank you. So, with that, I'm going to invite on Taoiseach, on Tánaiste, my apologies, on Tánaiste Micheál Martin to come, and I did have in mind to say the real Taoiseach in the real capital, but anyway, if we come in.
Thank you very much, Mark. It always sounds good anyway, nice to hear that word. But just our dúspáirte bhfuilm bhfuilchas a gháil de Mark agus an Criostóir socht an cride. Bheilibh madan ag an ócáid tochtach agus anna himúil seo. Cogádagus a dhéanamh libh a socht an dulcan chin atá le feiscint I rit na bliana. Agus níl éon áras mar a dúirt Dermot go bhfuil an scéal ag dul a bheos blian inig na bliana agus níl éon donna sin. Could I just say, first of all, I'm really delighted to join you all today on the 11th anniversary of the NET Patient Network here at the Oriel Park Hotel in Ballincollig. And to say, just listening to Dermot, and good to reacquaint, and having been a former Minister for Health, I think there's a number of key themes that emerged from his address, which at the political and community and societal level, we need to advocate very strongly for. The first is the centrality of the patient in everything we do. I was a former education minister. Education was my passion, and I often recall being told by Dick Langford, who was a head of the Cork City VC when he was doing the National Qualifications Framework, the levels 6, 7, 8, 9 and all of that. And he made a very good point when I was a young sort of member of the VC and emerging as an education minister, that education should be about the learner, not the institution. And we had at that time the tradition was the institution. So this university wanted that, this school wanted that, but the learner wasn't centre. Depending what school you went to, what third level college you went to, very often you were discriminated against, not in a sort of a deliberate way, but the outcome of that was. So by doing the National Qualification Framework, we developed the idea of the learner being centre. And no matter where you do your study, you get your qualification. In health, it's been a bit slower, and I've observed, and I've a lifelong interest in health matters since I became Minister for Health, but I suppose before that, my late father, prevention was always our sort of thing. And I learned a lot from him in terms of what can we do practically, diet, nutrition, all of that kind of thing. And I'm a pain in the butt at times when I meet people and friends of mine and they actually cover up what they're eating because they think I'm going to comment negatively. And it was a great friend of mine, Dan Wallace. He's still doing well, Dan is, but Dan had cardiac problems going back 30 years. And I remember one night he was inside in the Dáil restaurant and he loved his mixed grill. So I went in and he actually uttered a few expletives and said, geez, you've come in to ruin my tea. He said, he could see my kind of cranky look in the face and looking at him and so on. But the point being, in terms of health, the multidisciplinary idea is absolutely a no-brainer, and the centre of excellence is a no-brainer. But it took a long time to get it into the public consciousness of a no-brainer. I can remember election campaigns over the last 30 years, particularly in the 90s and 2000s, which reduced themselves to campaigns on a given hospital to retain a given something or other. And it made no sense. But to be fair to everybody, the communication of why it didn't make sense was not always well done, if you know what I'm saying. And very often you'd have disparate interests coming together, understandably, to protect what they would see as the hospital. But not necessarily protecting good medicine, or not necessarily protecting outcomes. And it was always a very challenging political exercise to sort of say it's about outcomes, not about where the treatment happens. And that can be difficult for families and can be difficult for patients when it means travel. When you create a centre of excellence, particularly in all areas, if you're a mother and father of a child, you have to go to Crumlin, that case. But it meant better outcomes. Very often there was a reluctance in some centres to send people to the national centre, feeling maybe they could do it themselves in the locality where they were. And I can remember when the first breast cancer centres began to develop, I can remember protests in Kerry and in Tralee, women coming to my clinic in Cork when I was Minister for Health at the time, saying, we want to keep what we have. And to be fair, he was a great clinician, but he was one surgeon, that's all. That's all they had at the time, but yet they wanted to hold on to it because of a fear of losing something, whereas what was being offered actually was much better in terms of outcomes from breast cancer. So that idea of multidisciplinary care to me is something I'm really passionate about, and it was fantastic to get the presentation. And I think in that presentation you saw the different disciplines that is required to get the optimal outcome. And when you're building up programs and capacity, you can't do it all in every centre at the same time. You've got to lead with one national centre, particularly in terms of specific areas, particularly in terms of rare diseases. And we had been slow historically in Ireland in rare diseases and in rare conditions. So I'm thrilled to see the progress that you have made in that regard. And also the idea of your network in terms of drawing together people from all over the country who have this condition and who, by coming together, you learn a lot more by just talking to each other. So you share experiences, and that actually empowers people, but it also consoles people, and it also gives people hope and a sense that there is a journey I can go on which will yield very positive outcomes following the alarm and the fear and the panic at a diagnosis that is a negative one. And this patient group has been instrumental in driving the improvements that we have seen in neuroendocrine tumour care and in outcomes for patients in Ireland. And that last chart, I think, was critical. So I do say to you that the network be very resilient, but be very strong in your advocacy for the right configuration in terms of how we structure our care model and centres. That's extremely important. Now, inevitably, by the way, when this all started, inevitably there had to be a strong Cork involvement. That's inevitable in the scheme of things, both nationally and globally. As a diplomat, I meet Cork people all over the world. And Justin Coyer, our ambassador, is a fantastic woman. Nuala Bryant was from Cork, from the Lower Road, from North Cork originally, and she was outstanding in terms of recent activities in getting citizens out of Gaza. But in this context, Criostóir, Súilleabháin, and Derek Power, who organised the international conference back in the UCC in 2011, and who've been outstanding advocates for patients and people that I respect hugely and thank for such an open attitude. You can ring them, you can talk to them about any patient at any time. That's hugely valued. So we thank you, and you organised that international conference, and were a number of papers at the time on nets were. It's okay, the voice is okay. I thought I needed the water, but I don't quite yet. And of course, one of the guest speakers at that event included the great legend and friend of mine, Tommie Gorman. And I think I remember watching the programme at the time, and like to me, Tommie was and is the personification of informative, balanced and conscientious broadcast journalism. And that is why his powerful account of his experiences of living with a NITS condition resonated with so many people across the country, and just almost overnight raised the profile of the condition and the disease, because people already held him in very high esteem because of his work in broadcasting, particularly the story of Northern Ireland, if I may say so, which has influenced us all, and that sense of the listening ear, advocacy, and given every opinion an opportunity to vent itself. And from Tommie and a group of other patients, you have formed this strong support and advocacy group for Irish NETS patients and the NET patient work. And we thank the guidance of Mark McDonnell. You've gone from strength to strength, and you've secured, that's the key point though, you've secured vital services. And I imagine from then to 11 to now, it's incomparable, the level and quality and range of services that are available. And you are contributing to better outcomes for people. And the national cancer strategies, they've got much better in strengthening patient involvement. And I'm thrilled to see the very strong links between clinicians and patient advocacy groups. I see it in my own city here in Cork, and I see it nationally. So for the first time this year on the cancer front, we've allocated €3 million for the network of cancer groups across the country, who like ARC here and ARC in Dublin, different groups, different names across the country. And that's the start. It's always, as you know, the clinicians will know, you get the foothold in first. And then you build on that. But the recognition and the concept is the first time dedicated funding has been provided. Again, understanding the importance of the patient and the role the patient can play in driving forward treatment. And we will continue to do that. And the NCCP in particular, and Ristéard and the team, you've put that now at centre stage also. And in fact, it was a recommendation I think that came out of your latest strategy, which we met with the various groups, and they had that sort of backing from you, which did help then in terms of decision making around the allocation of the funding. And I know, and I hear, and I know that I'll hear before the morning's out, the National Centre in St. Vincent's, satellite centres, can we do more? And I think Dermot made a very important point, that the capacity doesn't grow overnight, and you do need these multidisciplinary teams, but over time, that technology, in my experience, has been, it spreads. You can develop and acquire the technology for different centres once we've built up capacity, and the South obviously has a huge region to cover. And the big thing in health for me, which I don't think in public expenditure terms we've fully absorbed, is the dramatic growth in population. if you think we've grown 1 million, I think over 2 decades, that has huge impact on services. And it's an argument I make internally in government that we need to stand back and assess what are the real implications on health services with that growth in population. And that will mean choices for society. Just get the sense we're not presenting the choices to the public quite yet. But we are growing very significantly as a population. We're almost getting back, if you look at the island population, to the famine times in terms of, or perhaps our natural population growth. And then we're living longer, thankfully. And better outcomes and so on is contributing to that. I mean, the improvements in healthcare generally over a 20-25 period have been quite dramatic in terms of outcomes, particularly from the 2 big killers in earlier years, cancer and heart. Just been quite dramatic if you go back over 2 to 3 decades of where we stand. But all that then means increased pressure on the services, which means inevitably then that because of population growth and the regions will get stronger, and the cities like Cork, Limerick, Waterford and Galway are going to be regional cities at sort of an international level. That will mean stronger services and the kind of centres of excellence we are talking about to serve that growing population. And that's where the technology that you referred to, I think, comes into play in terms of how we plan to roll out that technology across the country in due time. I want to pay tribute to Professor Dermot as the national lead for NETS. Incredible work, incredible progress, and also the manner in which you presented to people in an understandable way. We thank you for that and for that leadership. And I want to thank the network for your leadership, for all of your activity, and in particular the Net Patient Network's website and social media platforms. They're overseen by Mary O'Brien and her carer Eoin O'Leary. And I want to give them a particular mention too, because this year's annual Patient Day is taking place at the venue where they held their wedding reception, the Oriel Hotel Ballincollig, which clearly brings back great memories and so on. And we thank you for what you are doing in that respect. So thanks to all of you for the invitation. I retain my interest in health with a view to making sure that we can get the better outcomes, that we can all live longer, enjoy life and contribute to life. And I look at it, there's a very good book written by Mark Henry, Ireland at 100. It's the most an optimist's guide. And it's sometimes in all this world of negativity and everything's getting worse or all the rest of it, it's worth a read. And the chapter on health in particular is worth a read. If you look at what was happening in 1922 in this country and look at 2022 in healthcare terms or outcome terms, it's quite a positive read, which gives us hope for the future, that if we do it the right way, and you're doing it the right way, we can really improve the quality of life of people with this condition, outcomes which will be of great benefit to you all. Thank you very much indeed. It's going to Eoin Paul.
So thank you, Tánaiste, for a really interesting talk, and thank you for joining us today. I know it's been a tough few days. So with that, I invite the Director of the National Cancer Control Programme, Professor Ristéard Laoide, and he's always been a great supporter of us and really understands the disease. So thank you.
Gur míl mágad Mark agus tá sé go húntaach ben seo I Gorcaigh ar maidin lív galéir agus is mór an ór dún galéir go bhfuil an Tánaiste an seoling ar maidin agus na háthar galéir tá sitin seo sa hala. I'd just like to thank the Tánaiste for coming today, because I think politicians get a bad rap, to be quite honest with you. Sometimes deserved, maybe, and sometimes, but often not undeserved. And it just reminded me when I met the Tánaiste just this morning that I go to various meetings as National Director of the Cancer Control Programme, and I was at a meeting here in Cork last year for the AMPs for cancer nurses. They're the nurse practitioners, and they were having their conference in Cork. And the Tánaiste also spoke at that meeting, but he, similar to today, he arrived from Europe the night before. He came into the hall, and he was 5 minutes late. And he sat down next to me, and he said, I kind of said, good morning. And he said, sorry I'm late. You heard what happened last night. And it was the Criostóir disaster that had happened the night before. And he had been involved in the discussion, and I could see it affected him personally, the whole disaster. And I just kind of thought, you know, he's come from Europe, he's come in here, he's come to this meeting, and, you know, just for an individual to do that was huge. And then I got into my car after the meeting, and I drove home to, well, when I say home now, I shouldn't say that as a Kerryman, but home in Dublin. And I sat down, and as I'm known to do, sat down and watched the 6 o'clock news. And on the 6 o'clock news, the Tánaiste was up in Donegal meeting the relatives of the patients, of the people hit by the disaster. And he's come here again today, straight from Gaza, and all the work he's done. So I think it's fantastic, and our politicians do it well. So I know he has had a great interest in health for many years, and you know, the National Cancer Control Programme, I'm the current director of it, but I think it's, as Dermot has pointed out, it's an important institution in our healthcare and how we organise our healthcare in Ireland. And I was on the second National Cancer Forum, which was brought together in the early noughties, and it was Minister, or the Tánaiste, that invited me onto that, group, which actually, out of which evolved the idea of a National Cancer Control Programme and the idea of the importance of centralising skills, and that's where it's come from, and that's how this neuroendocrine and the centralisation happened. And the picture that actually Dermot showed with the harp and myself there, that was actually taken at a meeting in Vienna earlier this year, and it was the European Society of Radiologists, and I'm a radiologist myself, and so the European kindly asked me to give a plenary lecture at that session, and it's a big meeting. There were about 30,000 delegates at it, and they were keen to hear how we organised cancer services in Ireland, and they were very keen to hear how a national, important word, cancer control, which is the important element here, controlling cancer in all its aspects, from prevention right through to survivorship, how that is done in a programmatic way in this country. And that's something that other countries are keen to emulate. And so I was asked to present that to this group, and the reason the harp was there was because the current, well, he's just finished his presidency now, and he's chairman of the European Society of Radiologists from Cork. And he's Adrian Brady, and he's a radiologist in the Mercy Hospital in Cork, and he was the ESR president, and he was actually organising that meeting, and the logo and the harp turned the right way was part of that meeting. So so a long-winded way of saying thank you, Tánaiste, and thank you for the support really over very many years for this thing. It's great news today to hear the PRRT programme has started and the first patient has been treated, and that's something that I know we've been striving for, and it's taken some time, but congratulations to Hussein and the team and Dermot in Vincent for doing that, and hopefully, as we say, that this will be actually made more available. I think the network is critically important, and I think this group symbolises for me the importance of the connectivity and the networking, and the Tánaiste has already mentioned that. And that's not in a trite sense, and I think sometimes when words are overused, they become useless in some ways. But networking is really important, and there's an old Irish saying, "Ní nart go cur le céile," and that is so true, and it means means no nart, strength, go cur le céile, until we come together. And that's critically important for a small community like Ireland in cancer care. And the Tánaiste referenced the educational institutions striving for their own institutional benefit. You ain't seen nothing yet until you see the hospitals. And that's the truth of it, you know. And I was talking at a cancer gathering in Croke Park, and I was saying, you know, that actually Croke Park was and the GAA is so fantastic but one of the things that we want to take out of general healthcare is the County Jersey model. And that's beautiful on Croke Park, and I love it as a Kerryman no more than anyone else. But we certainly do, yeah. But we need to put on the Irish jersey actually when we're looking at healthcare. And we can see that networking with Europe was very important, as Dermot spoke about. And Europe and the world, because the world is a small place. So, so sometimes decisions have to be made, but it really is to try and benefit everyone. But I think that the way to do it is that you have to do the networking. And the important things is putting there's subsidiarity is a word that was used many years ago, and subsidiarity is putting everything where you can do it most locally and most regionally and most nationally, where we just bring it down the line. And I'm from Tralee originally. I grew up in a farm outside Tralee, and Mahu, and we were talking about the breast cancer there and the centralisation, and I guess in Kerry they were worried about it at that time, and the green and gold was wondering what the red jersey was going to do to them. But, you know, that was the thing. But actually, I was in the Alliance Care and Recovery Haven 2 weeks ago. And they have a fantastic setup there in Tralee and Recovery Haven. And the huge amount of work. And I was asking them, how's it working with you in Cork? And how does the surgery work? And how does the... And they were very pleased. Everything was working very well. So it just shows that if people work together, and you have to respect, Cork has to respect Tralee, Dublin has to respect Cork, everyone, we have to respect each other in how we do this thing. And so the subsidiarity is very important, but centralisation is very important as well. So the Laoide Care project that's part of the government for the development of healthcare, that's really the crux of it, is that where you can deliver the care locally, but high quality care locally, do it there. But when you can't, you have to centralise it. So that's the whole drive from the NCCP, and we want to do that also in not only in the healthcare, but also in research. And one of the things that's happening in this country is people are getting the units are getting OECI accredited units. Now, one of the thoughts that I'm trying to drive with the Department of Health is that we need to network those centres together, because there's no centre in Ireland that can compete at an international level in its size for as being a comprehensive cancer centre. Now, ideally, would, you know, someone, if we had a magic wand and said we'll build one cancer centre in this country and it'll be like Sloan Kettering, that ain't going to happen. So certainly not probably in my lifetime. So what you need to do is you need to network the centres together, and we have to use policy and fiscal, if you like, measures to drive that networking together, so that people don't say, well, I'm a such and such a cancer centre, and the feeling I sometimes have is that people say, well, I'm the city on the hill, the citadel, closed off. But actually, you have to be the beacon on the hill if you're going to be a good centre. You have to be a place that draws people in and helps people, so that the man in Belmullet or the man in Ballincollig or the woman in Bantry is going to get the same care as anyone else in this country, and that's really important to me. So I guess why the neuroendocrine group is really important is that you network together, you network with the clinicians involved in your care, and I guess you and maybe possibly the sarcoma group or another group that do that really effectively and well, not in an overstridently way, but in a confident way, and that's really important. And then the clinicians network together, and they network with the universities, and when you do that, you get the best results for the patients at the centre of all of this. So that's something that I thank the patient group for, because you're an exemplar of that for other patient groups in this country. I don't want to go on, but I'd like to thank the Tánaiste as well for the €3 million, as he said, that he announced in the Dáil and that the government have given to the community-based cancer services, because they're critically important as well. And they're voluntary, a lot of them. And people give of their own money to support these centres. This is a method by which both the state and the community works together. And that again, I think is critically important for community and state to work together, because the state can't take over everything or shouldn't take over everything. So this is wonderful that these units are doing it. And hopefully, This will be sustained funding, that's what we're hoping, down the line, and we in the NCCP are hoping to work with the various units, the community support centres, to deliver this money, but also to support peer support for these various groups and to keep the standards high. We continue to work in the cancer NCCP around centralisation. Last week we formally announced the sarcoma service. There's a national service in St Vincent's. It's going to be the sarcoma hub, and there's going to be a satellite unit in Cork, because there's been a lot of sarcoma services delivered here in the south also. So again, it's part of further networking and further development for rare tumours. I'd like to thank Dermot for the huge amount of work he's been doing in leading neuroendocrine services in this country. He has an international standing, and that kind of really, that helps us really as well, because it connects us into the international community. I'd like to thank Mark, particularly for leading this group with Tommie, who've done great work, Tommie Gorman, on it. And I'd like to thank Criostóir and Derek for all their work they're doing on neuroendocrine care in Cork. And I guess I was down, and you think I was down in Cork the whole time, but I'm not. But I was down a number of weeks ago at a meeting on pancreas that was done here, and was a wonderful meeting on pancreatic cancer and other rare cancer. And again, at that meeting, I think everyone agrees the idea that we need to network together, we network more closely, and for the benefit of our patients. So, Míle buíochas is Rish, gur míle maith go léir ben seo, agus is únta bheith back a raisi gorca go Rish.
So, we will be breaking very, very shortly, but just in response to the talks we've had, I want to invite Tommie Gorman, the founder of our organisation here, and just to give a quick update on where we are and what's happening.
Thank you, everybody. Tánaiste, I looked at you in Israel, and I looked at you dealing with Gaza, and I'm sure it made you conscious of our peace process and how much we have achieved in our country with all its flaws. And just that wonderful sense that on this island we have stopped killing each other, and that anger is unlikely to return. It just puts in context the possibilities that politics offer. So you get home yesterday, 9:30 this morning, you're in the car again. We're your first marking. And this is your business, this is politics, this is your life. This is the life of somebody who's involved in public service. And you've also come through the decade of centenaries, when we looked on our history as a state, how it emerged, the journey we've travelled, and where we might be going, including returning to a situation where we're now 1 million shy of what our population was at the time of the famine. In the same time, the population of the world has increased 6-fold. Population of Britain has increased 4-fold. We're nearly back to where we started, but it's a time of immense possibilities. And this is our vehicle as citizens of the state to try to exercise our responsibilities and to access our rights. That's what we are about as the Net Patient Network. Our journey is so interesting in many ways. When I was diagnosed back in '94 in Belgium, there was nothing here. Nothing was organised. '98, I accessed care in Sweden through my rights as a European citizen. But soon after that, Donald O'Shea came to me and said, look, could we work together? Could we try to improve services? Could we work on this concept of a centre of excellence? Your former colleague, Mary Harney, was the minister we first spoke to. She was vital in helping us build that concept of a centre of excellence established in St Vincent's Hospital. You're 100% right that it was a conference in UCC. The late Jerry O'Sullivan was at it. These two boys here, Criostóir and Derek, helped to organise it. And from that came our patients organisation. That's where the concept was first discussed. So that's the fruits of their labour. So we had a centre of excellence, but we needed a national lead. To get a national lead, it was a really generous thing for Donald O'Shea to say that we should get the best. So we went looking for the best, and the best was identified as Dermot O'Toole, and he has been our national lead since. And we had to box clever, because it was, in a way, it was a bit like a hedge school. We're trying to move from hedge schools to prefabs to proper buildings and proper facilities. So we had our hedge school, but we still had to access treatment abroad for some of the most intricate procedures that would keep us alive, but we needed to do it in a cost-effective way. And for that, the E112 system was so vital. Our right as European citizens. But it could be one of these things that the HSE would say, no, oh, you haven't filled in that form, you haven't filled in the other form. And only because the HSE approached us in a positive way, helping us in every way that could. It's only because of that that a lot of people in this room are alive today. It's as basic as that. And Catherine Donoghue from the HSE is the person who runs that treatment abroad scheme from Kilkenny. And she is our friend, and a great friend. And I'd like to acknowledge her today. So then we start to build our service. And in a way, it's energizing for us as an organisation that we can have this collaboration. It's like a Micheál. I love the way you and Ristéard break into our native tongue. Well, I'm going to remind us all of what Michael D. Higgins said at that state banquet in Windsor Castle, or Scorachéla, Awaramid. We live in the shadow of each other. We support each other. That's the notion of community. That's the way it is. And that's the way we have our arrangement as a patients' organisation. It gives us the capacity to get the best out of the system. It also gives us dignity. It gives us opportunity. And this really is a historic day. My wife would kill me if I said an historic day. It's a historic, she'd say, Tommie. So this is a historic day, because for the first time, we have started to treat PRRT patients in this country. Now, some of us are well able to go to Sweden. We actually like it. But there are people who are older, sicker, and to have that facility in this country, that is a significant achievement for the state. It really is. As well as working with the medics, with the pharma companies, we've had a dream relationship with the NCCP. Tom Keane was gone. Susan O'Reilly replaced him. Jerome Coffey came after it. And Ristéard is the successor. And they are our friends. They are part of our Micheál. They are part of our cooperative. So we have in place PRRT. And we're going to have to build up the flying hours and the competence of that system. But as patients, because we need this service to stay alive, we become conscious of where there are flaws or inadequacies. Where we're losing out at the moment is we don't have enough gallium scanning in this country. The wait is too long. Gallium scanning, in a simple way, gallium scanning is like sat-nav instead of drawing out a map or looking at the signposts. So we need sat-nav. We need an improved gallium, more access to gallium scanning in this country. Whether it's a second centre in Cork, whether it's improved throughput in Vincent's, whether it's a combination of both. The numbers are growing in our patient cohort. So if we are to keep this system humming, that's just one thing we need. And that's really what's going on as part of this discussion. That's why we're having this session, so we can have that opportunity to just lay it on the table. This is our assessment. This is our ask. Finally, I just want to make a point about our organisation itself. Since we were here last year, we lost 2 of our committee members. Carmel Connellan died, and Adrian, who from Wexford, who was the heart and soul of the party here last year. Adrian's cancer came back with a vengeance, and Adrian died. And part of us die with him when that happens. But the way our organisation is, people step forth. There's a young girl in this room from Castlebar who lost her mother to our disease. She is now working on our newsletter. She doesn't have the disease, but in recognition to what was done by the system for her mother, she wants to make her contribution. Another story. There's a woman here, met her last night for the first time, from Súilleabháin. And this brought such a smile to me. She went into her GP. And this goddamn disease is so difficult to diagnose. And even when you diagnose it, it can be so difficult to get the right treatment. You can end up getting the wrong treatment. It has happened to some very famous people outside of Ireland. It happens regularly. So getting the right diagnosis and then the right treatment, you're on the right path. You're having the best chance of survival if that happens. So this woman went into her GP in Súilleabháin. She had some digestive problems. And he was interested in her. And he said to her, I think you might have nets. That rarely happens. That was fantastic. And you know, the way life works out, the GP involved is a brother of James Riley, former Minister for Health. So that's a great story for us. But there's a tale to it. That woman and her sister and her family, she has her diagnosis. Of course, it's frightening as hell when you're told you have cancer. When you're told you have liver cancer, people start walking away from you. When you're told there might be a pancreatic problem too, well then they say, oh, you're finished, you're jiggered, which isn't the case. So, this woman, armed with her diagnosis, what does she do? She and her sister organise a coffee morning, and they raise €3,500 among their friends. That's her response. That's her positivity. So in summary, Tánaiste and fellow members, this is the forum where we try to build our country. This is the vehicle. This is the challenge. This is the opportunity. And as someone who steps off a plane, goes home for a few hours and is back at it the next day, I hope an occasion like this energizes you and gets you to see that really good things are being done in this country. And we, as patients, with our families, we're very happy that's the case. Thank you. I have one very pleasant responsibility. I'm going to ask Mark to make a presentation to you of a beautiful bowl that's over here in this box. Mary might be able to put green tea or fruit or something like that in it. I'm sure the house is full of them, but and it'll be Barry's tea.
very much, Tommie. I know when I was first diagnosed with NET on my pancreas, and there were an awful lot of long faces, and I'm still here 7 years later, and a couple of surgeries later, doing fine, thank God. Tommie was so supportive when I was first diagnosed. I knew him from work before and just texted him, and I'd hardly pressed send, and he was on the phone to me from a car park and playground in Belfast, and giving me so much reassurance. And if anybody gets a long face now when I say, well, I have a form of cancer called NETs, I just say, it's what Tommie Gorman has. He's had it for 25 years and it hasn't killed him yet, and they relax. So I think let's take comfort from that. Now, Mark and Tommie have left with the Tánaiste. They are having a very important meeting. Once again, we're very thankful to the Tánaiste for his time about lobbying for gallium PET scans here in Cork. I can say myself, I'm another patient who's benefited from a gallium PET scan, and it really, it sees absolutely everything. And it's a fantastic facility to have. So I hope, well done, Mark and Tommie, and I'm sure the Tánaiste will be receptive. And now, finally, I'd like to introduce most people when they're first diagnosed. The first thing they do, what do any of us do? We go online to find out what we can find out. The people who have been responsible and who have been utterly dedicated to providing online support through the website and the Facebook page are Eoin O'Leary and Mary O'Brien. And exactly. The personal dedication and service that Eoin and Mary give, and the one-on-one reassurance they give is amazing. So thank you, Eoin and Mary.
Yeah. Hello, everybody. We would like to welcome patients, patient family members, doctors to Cork, the real capital of Ireland. I got involved with Net Patient Network Committee first because of my journey. I wanted to do more for patients to have a voice. So when I got involved with the committee, I was saying, look, I found support from groups in America, around the world, and I said, we need our own Facebook groups, because that's where social media is going, and if patients get somewhere, they can talk to other patients. So, of course, there was a little bit, we don't know about that, and I kept on saying, look, there's a need for it. So we eventually got it set up. Sorry, my voice will go because of my lungs. So both myself and my husband then, we set up the Net Patient Network page, the support groups. And then from there, we now have 400 members in the main support group, and we have 175 patients who are strictly patients in the patient support group. Now, the Net Patient Network private patient group is a strictly patient group for patients who discuss with other patients things in private. Because if you have a family member in the group, you might be a bit uncomfortable and you'd rather talk to another patient. And that is a vital service, because it could be upsetting for your husband, your wife, your daughter, your mother, whatever in the group, to hear that you are having these problems, and I would like just to talk with another patient only. So we are extremely thankful for the doctors who give up their valuable time and attend our event and are there taking care of the patients, because that is a vital service that wasn't there when I was diagnosed. When I was diagnosed by a lung specialist, a year later he told me I was cured, and I got into difficulty, ended up back inside this UNH, and as an oncologist came on and said to me, do you know that we have a NET specialist here in the hospital? And it was then that Derek took over my care, and by Derek taking over my care and doing 6 months checkups and everything like that, and sending me to Uppsala, and eventually they found out that I was diagnosed in 2012, had the surgery. In 2017, I had reoccurrence, and in 2018, I had another major lung surgery. And without me finding Derek Power, the NET specialist, without getting involved with the team in Dublin, without going to Uppsala, without the care, I would have never known about the recurrence because I was told I was cured a year later. So this is vital that we have the service, we have the teamwork, we have the Centre of Excellence. This is vital because it needs to be a combined effort, and we need to work on that. If a patient is diagnosed with NETs, that they're sent to a NET specialist. Even if you don't attend the NET specialist, that their case is studied, and we have a teamwork then that you can get involved. If you need help down the line, if you're getting symptoms, your case can be discussed, and this is a vital part of the service. The support groups have grown in strength to strength, and it's great seeing patients helping other patients that are there to offer support advice to other patients. But we need to get patients to continue to get involved and be there to answer questions and offer advice. Because I might not know something about pancreas, or I might know something about this, and patients ask for advice, and we need more of that, that patients say, look, I have this experience, I can learn to help others and stuff like that. And by that is teamwork. Now going forward, we need a patient body system, like I suggest, that if you have an issue, that if you put a question in a group, that somebody will say, I have the same experience, I'll be a patient body to you, and even just to be there to help somebody, I can offer you my phone number and private message, and I can be there to support you, because we're finding that patients join and they're asking questions and they're still feeling alone. So if we could get a patient body system going, that you could say, look, I have this experience, I can help you go into Uppsala, I can offer my number, I can be there to help you. And then for, I would like if family members could offer a support to other family members who join that, look, I know it's upsetting for my wife, for my husband, my daughter, my son, I can be there to her. I can give you my number, we can talk things over, and I can be there to help you. So that is something that I would like to see going forward. Then I would like to thank the Irish Cancer Society. I can't see who are here today. Yes, both of you. We would like to thank you because on November 10th, which is Net Patient Cancer Day, and it's a worldwide thing, you actually posted this year on your Facebook thing, and we'd like to thank you because I have been advocating with you for years trying to get it done, because more and more people will see it and more people will recognise it. Now, we still need patient members, we still need family members, we still need them to volunteer, to offer, even on the Net Patient Day, to help us if we need somebody to do something. And throughout the year, we still need people to volunteer, because as patients, we might get sick and we might need other patients to step in to offer to help. And then for family members, we need more family members involved, because I know my husband Eoin does a great lot of work, and Margaret has offered now to help her. Is it? Yeah? Yeah, has offered to help. But more family members that you can offer to do something simple anytime during the year if we need help, because it's by teamwork that we're all going to get things going forward and see progress. So that's everything. Thank you.
Okay, I'm going to cut mine very short now because I was told that there's coffee on offer, so I need my coffee. It's not here now, I didn't know Mary's after eating. The amount of time that you would need to spend as a volunteer if you decide just to do the buddy system or anything is very, very small. You're talking about, 20 minutes, half an hour a week, even if you do find someone that's in real trouble, if they're newly diagnosed, that's all you're talking about. It's not a huge commitment. At any stage, due to the fact that everyone's patients, you can simply say, look, it's too much, and just step back and we get someone else to fill in, there's no problem. So don't be worried about commitment. Mary has been sick for, God almighty, 12, 15 years now, and she's doing, you all see the work she's doing. So it isn't a huge commitment to actually do it. And if we can get a bigger group working together, it'll make this awful lot stronger. Because as a group, as you've seen what's been achieved over the last 11 years, that is mostly a few people that have been up here all the time talking, doing the work. Look at what we have at the other side of the podium. Everyone here has a voice as well, and you all know what you need. And if we can get a big group going forward as well, that's a far better push to try and get things forward. Okay. cut down. Okay, the Facebook group. I found the quickest way to, if you want to join the Facebook group, if you want to take this down, if you go to the website, which I'll give you the details in a second, and all you have to do is look at the top for patient support. So up on top there's a menu, patient supports, and look down that and you'll see Facebook group, and just click on that and that'll follow through then very quickly as to what you need to do. Because we're stuck on all this GDPR thing as well, so you actually have to sign in and voluntarily put your details in. We can't just take your email address and put you into the group. So that's how you do that. If you're not sure how to do it, just catch one of us later on and we'll show you. For carcinoid, let's cut this down fierce now. For carcinoid syndrome patients and anyone with carcinoid crisis, I would like to thank Dr. Hussein. Last year we spoke about this at the Net Patient Day, and he said he would do it. He stepped up and got it done for us very, very quickly. And it's all running now. And basically, we have a letter now on Net Patient Network letterhead as a PDF document that you can download. It has all the details of both maintenance, prevention, and if someone actually goes into carcinoid crisis, what you actually do. So you have this letter that you can bring in at the start of any consultation, so that you can actually get them to see this is the situation they're dealing with. It has all the contact details of St. Vincent's, so if they're not sure, they can simply ring and get confirmation. And because we realise you can't go carrying around a piece of paper with you all the time if you have carcinoid syndrome with possible carcinoid crisis, if you go to, where do we down my shortcut? Yeah. So I've set up a domain called medicalert.info. And if you go to that, it brings you directly to the page on our Net Patient Network website that has all this information, plus the link to download, etc. So you can put that on a card, and if you were any time in an emergency situation, you can pass the card across and say, look, please go here, you need to look at this information. I choose, oh, there we are, there's my 10 minutes. I chose Medical Alert in the hope that an EMT or someone on the side of the road, if you were in a car accident, would see it and they wouldn't just switch off. They'd see Medical Alert and they'd actually do it. And that would get them to hopefully to go to the site and end that problem. So that's a short version of that one. The website. So we've vastly improved the website at the moment. We have a system on site on the website now so that every time Inca make a document or they change a document, we get that updated document all the time. So we're continually up to date with all the information coming in from Inca. So there's no longer a PDF there that hasn't been updated in maybe 10 years. It's fully updated all the time from Inca. We have 2 domain names now. They're the wwws. And just to explain them, we've got netcancer.ie. That's more or less the main one because it's short and it's quick and you can explain it to anyone or you can say it to a doctor, etc. It's easy to remember. But we also have neuroendocrincancer.ie because that's the one that people will be typing into Google. They'll type in neuroendocrine cancer and they get it. So that's the function of both of those. They both go to the same website. There's no difference in the information that they both go to the same website, just different purposes. So you can use either or the 2 websites. So the last thing is, this year especially, the patients have been very, very good in the groups. We've had fierce interactions with the patients and that, and it has helped to help newly diagnosed patients, but it's also helped to see holes in the system, what's going on. And I do think we need to think about this once we start moving forward, because we have a centre of excellence in Dublin. We're moving on to do the same in Cork. But the excellence in what is happening when the patient leaves the consultation and has their next one and they're in trouble, that hasn't been dealt with yet. We really do need to do that because too many of us are ending up inside an A&E because if you're not able to get to St. Vincent's on the Thursday or Friday, A&E is your only option. There needs to be another option there for us to contact someone to get into the system so that someone can alert as to what's actually going on. So we're going to try and see can we push that now over the next, hopefully a year, but probably longer than that. But that's what we're trying to aim at, so that when you're in trouble, you don't have to go to A&E and spend hours inside there. You know, you have a number to ring and that will hopefully get you through the process. So that's it for us, and thank you for all the patients in the group. We wouldn't have a group if you were not there, and we wouldn't have a group if the feedback wasn't coming in from you all the time and the questions weren't coming in, because it makes us feel worthwhile when we see a question coming in from someone literally panicking, and then at the end of it they're totally informed about what's going on and they know what to do. So thank you everyone, and hopefully enjoy the rest of the evening.